Just a minute. Okay. So you can see the full slide, isn't it? And I am audible also. Okay, so today we will talk about pain pharmacology. We have already talked about pain anatomy and physiology, and anatomy physiology is very much related to the pain pharmacology. So, first thing, our treatment approach for any patient, our treatment approach is in two parts. One is symptom management, and second is modifying the background cause. We should know the treating the background cause, you can say. So what is symptom management? It is always targeted to the pain generator. Means one structure is causing the pain. That structure can be a joint, can be a ligament, tendon, whatever there is in our body can cause pain. If it is supplied by the pain fibers anatomically, then it can cause pain. So why that area, that structure is suddenly causing the pain, because that structure is there in your body since birth. So suddenly it is causing pain. That is the pain generator. So the reason behind the structure being the pain generator is, we will say, that modifying the searching for the background cause. So always when you diagnose a patient of pain, you will think that there are two parts. One is directed, our treatment is directed to the pain generator, and other part of treatment is directed to the background cause. Symptom management at the pain generator, first let us discuss, and that only we can discuss because background cause, it is so diverse, and many a times if it is degenerative, then most of the time degenerative things comes to pain physicians, so that is non-modifiable. And if it is inflammatory, then of course we will also go for, say, inflammatory arthritis, we go for that treatment. And many other things like trauma, malignancy and all, we need other specialties. Okay, so here mainly we are talking about the pain generator treatment. So means for pain generator treatment principle, what is the principle? It is multi-modal and multidisciplinary. What is multi-modal? Multi-modal means for treating the pain, we will use all types of advances in medicine. Okay, all types of treatment. So it can be simple oral medicine, it can be intervention, or it can be, of course, we will not go for surgery, but then other methods like, say, orthotics, physio, those other things also we will go for it. And so this is called multi-modal. Okay, and if it is, say, psychological counseling and all, or physiotherapy, so that is also part of multimodal. But then everything is not administered by us, so that then we need the multidisciplinary treatment. Wherever required, we will refer the patient to a physiotherapist, we will refer the patient to a psychiatrist. Most of the time these two specialties are always needed, many times needed for treating the patient completely. So this is our principle of treatment: multimodal and multidisciplinary. Now comes, let us recollect the pain of parts of pain pathway. So one part was transduction, then transmission, then comes modulation and perception. You remember that what is transduction? Transduction means it is the starting of injury to starting of action potential, from chemical to electrical activity, chemical activity to electrical activity, that is transduction. As soon as the electrical activity or action potential starts, then we will say it is transmission. Then comes electrical activity can go through the spinal cord, spinothalamic tract, and then thalamus, then cortex. So that is the transmission area through the pain pathway. Then comes modulation. So modulation can be of two types: either it can decrease or it can increase the pain. Now, in normal condition, it always our body tries to dampen the perception of pain. So how we later I will say how we use that part. And modulation can increase the pain also. That is in a pathological pain, where it is when it is a neuropathic pain. And perception is ultimately when we are perceiving the pain. Means it is not only the nociception, nociception, and cognitive modulation. How we do feel about that pain, total amount is our perception. So this is the parts of pain pathway. So transduction area, just see that what is there. I mean, in transduction area, chemical to electrical. Okay, so it is mainly the prostaglandin pathway. So in prostaglandin pathway, when there is injury, there is phospholipids are skin from the skin. It is there phospholipids. So phospholipase A2, that is acts on the phospholipids and form the arachidonic acid. Then cyclooxygenase, lipoxygenase, these COX basically, they form the prostaglandins, different type of prostaglandins. Some prostaglandins are good and some prostaglandins are bad. But when mainly this is the area when we want to stop the pain, then it is a we have few drugs, that is one is NSAID and one is steroid. When we stop the arachidonic acid formation, that means we are stopping the phospholipase A2, that is done by steroid. Then we are treating at the transduction area of pain pathway, but by one step higher. I mean, like in phospholipase A2. When we are stopping the COX part, mainly, this is not the LOX part, that is a different group of drug is there, of course. But then COX drug, cyclooxygenase, anti-cyclooxygenase means COX-1 or COX-2 inhibitors. So COX-1 inhibitors we don't need. We need COX-2 inhibitors. Remember, COX-2 is the pathological COX, cyclooxygenase. In a physiological condition, if there is no injury, then COX-2 is not there. It is only COX-1 which does the physiological functions. We want to mainly stop the COX, not COX-1, but we have the formulations which are non-selective. Many formulations, NSAID, like say diclofenac, brufen, ibuprofen, all what we use, they are non-selective. So they not only stop COX-1, they not COX-2, they blocks COX-1 also. So when we are writing some NSAID, we are blocking COX, okay, cyclooxygenase. So you can understand our normal physiotherapy, NSAID or steroid, they mainly act on prostaglandin pathway. Steroid at one step above and NSAID mainly one step below. Okay, ultimately prostaglandin formation is stopped and the inflammation part is reduced. Now comes transmission area. So what happens in transmission? In pain pathway, remember transmission is actually a game of neurotransmitter, receptor, and ion channel. Neurotransmitters come and join to the receptor. Ion channel, as a result, ion channel opens. There are multiple type of ion channel, that metabotropic, ionotropic, and others also. I mean, cations can pass, anions can pass. So these are, if you go in depth, but that is not needed. Only thing is that neurotransmitter comes to the receptor and ion channel opens. Effect can be inhibitory, can be excitatory. Excitatory means pain action potential is going forward and patient is getting the pain. And inhibitory means action potential is stopped there. I mean, it is not not action potential stops. Actually, the effect is inhibitory. Patient's pain will be reduced. So ultimately, these are the neurotransmitters: substance P, CGRP, glutamate, aspartate. So these are all, mainly substance P and CGRP are the important neurotransmitter which causes the inflammation and causes a excitatory effect on the receptor. Ultimately, the ion channels are mainly of calcium and sodium, that I'm telling. But then these are you just remember the neurotransmitter: substance P, CGRP. These are excitatory neurotransmitters. They work on receptors which are excitatory, like NMDA, AMPA, or NK1. These are neurotransmitters excitatory. So ultimately, pain will propagate. Pain action potential will propagate and patient will have more pain. Next, there are some inhibitory neurotransmitters. So what are those? So beta, endorphin, enkephalin. So these are inside in our body. I mean, these are endogenous endorphins, I mean. So beta endorphin, enkephalin, norepinephrine, and serotonin. So remember these two names, norepinephrine and serotonin. Of course, GABA and glycine are also inhibitory neurotransmitters, but for pain treatment, norepinephrine, serotonin are more known to us. So these are inhibitory neurotransmitters, and they work on these receptors. So they can be opioid receptor if it is enkephalin beta endorphin type of drug, and or it is serotonin works on the 5-HT1 receptor or ST3 receptor. So this is the receptor. GABA works on GABA A or GABA B receptor. So these are the receptors names. So this part you have to memorize, that there are excitatory and inhibitory neurotransmitter and receptor, and this is the net result, that either the pain signal will propagate or not, or it will stop there. Specific receptors, I am not going in the specific receptors, but NMDA receptor, 5-HT3 receptor, there are multiple very important receptors for pathological pain, those who are the neuropathic pain. So what happens here? There are some ion channels also. There are different type of ion channel. So I mean, when I'm talking about the receptor, then what actually happens? So you see, whatever be the receptor, no matter what is the receptor, ion channels are more or less same. It is calcium and sodium. Of course, potassium and chloride are also there. Chloride is an inhibitory chloride channel is a new inhibitory channel. I mean, that ion is inhibitory, gives inhibitory effect. But you just remember calcium and sodium. These two ion channels are mainly gives the excitatory effect. So everywhere, whatever be the list of this neurotransmitter and receptor, when it comes to the ion channel, then it is either sodium or calcium which propagates the pain. So how we can? So there are multiple types of ion channels. Names are different, but ultimately what it goes passes through it, that is calcium or sodium. So, what is importance of knowing this? So, remember, if we can stop a direct excitatory neurotransmitter, we can block, then pain will get reduced. If we can block an excitatory receptor, then also pain will reduce. But in the case of inhibitory receptor or neurotransmitter, we want to increase their power. We want to increase their power so that their inhibitory action increases. Okay, so this is the main strategy. Remember, anti-substance P or anti-CGRP is not there in the market. It is at the experimental level. Rest of the things you can get, like NMDA, AMPA receptor drugs are there, or the these receptors, inhibitory neurotransmitters, you will get drug, or this inhibitory receptors also you will get the drug. Okay, so this is the ultimate when we will talk about other drugs, then you will understand that okay, how it is important. Modulation area. Now let us remember the modulation area. So here, as you understand, that this is the inhibitory part. Okay, so this is normal. This is normal in our body. It is always trying to inhibit the pain signals. Okay, so we can take care of, we can make some use of this inhibition modulation area. Modulation area we can use. How? So if we strengthen the inhibitory signals, okay, inhibitory pathway, then one option that will decrease the ultimate pain signal, and patient will get less pain. So how will increase? So descending inhibitory tract. If we want to increase, then we have to work on adrenergic and serotonin. This descending inhibitory tract work through adrenergic and serotonic and opioid receptor. So remember this chart here, as I said, adrenergic, norepinephrine and serotonin. So, and then opioids are also there. So these receptors, through these receptors, this inhibitory channel works. So we have to provide some drug, so which increases these inhibitory receptors at the synaptic cleft or at the dorsal horn area. So there are some drugs like SNRI, NRI, even the NMDA blockers. So these also have some additional effect, mainly SNRI and NRI. So what they will cause, they work through these phenomena, and they will increase the power of descending inhibitory tract so that patient gets less pain. Now another thing is gate control theory, glycine GABA, pain at a different site. So pain at a different site doesn't have any clinical application. You cannot if someone has one hand pain, you cannot make increased pain in another hand so that he doesn't get pain of that hand. So this doesn't have a clinical application. But then gate control theory. Gate control theory is a segmental inhibition, so it has an application. Remember, when we always have seen that after an injection, whoever has given the injection, he rubs the area so on the skin. So that is a application of gate control theory. Like you are stimulating the A beta fiber, okay, and which is stopping the A delta fiber at the gate. Bigger, thicker fiber will stop the thinner fiber. A beta, which is taking the sensation, it will stop the pain sensation of A delta fiber. So this is one application, for example. But how we use the same thing like gate control theory? Because wherever we do neuromodulation, it starts from say TENS. TENS is also a type of neuromodulation. Then we can go for in the spine, peripheral level, say peripheral nerve stimulation, or in the spine, it is spinal cord stimulation. In the brain, you have heard about DBS, deep brain stimulation. From the skull outside, it is transcranial magnetic stimulation. All are actually if they may have different other mode of action, but main action is gate control theory for pain purpose. Okay. So this is one thing. So we can take use of gate control theory, or even we strengthen the descending inhibitory tract. And here modulation part, here as I told you, in pathological area, it is the sensitization which is the culprit. So we have to give some drug so that this sensitization stops. So this sensitization of the wind up receptor field expansion and all, this stops. Okay, so there are specific drugs for that. Like NMDA blocker is one of them, and gabapentinoids and all one of them. So perception area, what can we do here? Here only we have understood that these areas, prefrontal cortex and all, the sensory area, sensory discriminative and emotional affective, both the things together gives the perception. So there are something like CBT, that is cognitive behavioral therapy, will take care of this part, emotional affective part, so that patient can handle the pain. It is the augmentation of pain will not occur. So, this is this is what I was telling, multi-modal therapy. Here, different model of treatment, different treatment is given targeting different parts of pain pathway. Here, remember one thing: one drug can act at 2-3 areas of pain pathway, and so this is possible. I mean, it is not that a single drug will have only effect at the one site. Okay. So until now, what we have understood, transduction area mainly target the prostaglandin pathway, mainly by steroid and NSAID. In transmission area, target receptors by NMDA receptor antagonist and all. These receptor, NMDA receptor, opioid receptor, GABA, HT. So inhibitory receptor, we will give more power to them, and excitatory receptor will stop their action. And ion channels, it is the sodium calcium. So we are forgetting the receptor and neurotransmitter, we can block the ion channel also. So mainly sodium and calcium. Modulation, target receptors here also, opioid 5-HT and norepinephrine NMDA. So by this thing, we will stop the modulation. In modulation part, they will use we will use the drug which attacks these areas. Perception part, only CBT. Placebo, non-traditional different methods, actually they most of the time they work at the modulation or perception level. not at the transmission or transaction area. So just one more thing, clinical approach. So you have understood how pharma. This is actually a summarizing that how the pharmacotherapy is related to the physiology and anatomy. Okay, when we give a drug, it is not that we are memorizing the drug's name and just writing. We know in our background of mind that at which area I am attacking, and you cannot give two drug at the same by the same what should I say? I mean same mode of action. Then two calcium channel blocker you cannot give, like say gabapentin plus pregabalin. You cannot write. That doesn't have any use. The patient will not get more pain relief, but will get more side effect. So while writing, you must consider these things. Like you are giving carbamazepine, you can add gabapentin also, because one is blocking sodium channel, another is blocking calcium channel. Okay, so here clinical approach. Remember, as I told you in the two parts, that one is pain generator treatment and another is background phenomenon. Now, in pain generator treatment also, background phenomenon we are not talking about. So in pain generator treatment, first step, second step, third step, medicine, intervention, and surgery. Now, this medicine part is same as everyone else. Whoever see these patients are not unique to us. They are seen by many different specialties. Now, second step intervention is actually very, I mean, strong USP of our this pain medicine subject. Okay, third step is surgery, that sometimes we need to refer if there is any red flag sign. Okay, plus other disciplines, whenever needed we will call them. So this is a clinical approach. Here, the second part I am talking about intervention. We when talk about what we do by the intervention, targeted thing, that what we do. We are when medicine has failed and we have thought about interventions to stop the pain at the pain generator. So first thing, take care of local inflammation. If there is any local inflammation, you can take care of that. So that is one mode of treatment if there is inflammation. Second thing is regenerate the structure. So most of the time, if it is an acute inflammation, that there is inflammation, it is a acute presentation. Patient is coming with a acute presentation, swelling, redness, and redness is there or not, but in swelling and acute pain, acute exacerbation of pain. So there you go for steroid-like drug or NSAID, because you are taking care of inflammation by prostaglandin pathway. Okay, regenerate the structure. This is a say dull pain. It is going on and on, like say impingement syndrome of the shoulder. In general, patient doesn't have pain. When patient lies down on that side of the shoulder, then only he feels pain. Or if he does some overhead work, then only he feels pain. So in those cases, you can go for regenerating the structure, because there is degeneration. There is no inflammation. There is degeneration. You can go for regeneration. What are the drugs mainly? Regenerative drugs are PRP, dextrose, ozone. These are we are using in our daily practice. There are multiple drugs. So these are for regeneration purpose. Third thing is target the nerve supply. So you see that there is nothing to regenerate, or there is no inflammation. There is a say damaged joint, completely damaged joint. So there is no inflammation and you cannot regenerate also. That is gone case. So in that area, what you can do, you can target the nerve. What you will do with the nerve? You can either ablate the nerve or do modulation of the nerve physiology. When you ablate the nerve, you do something about anatomy of the nerve. When you do modulation of the nerve function, then you do something with the physiology of the nerve. Okay, and remember, we are targeting pain fibers, not the motor fibers. But sometimes it is I mean both the fibers are together, then we have to do some different methods that Dr. Devjyoti will say. So here actually ablation is done by radio frequency, cryo, or chemical neurolysis. Chemical neurolysis means alcohol, phenol, those things. So these are for ablation. And modulation means neuromodulation techniques. Though one type of RF is there, that is pulsed RF, that causes modulation. So remember, One is anatomy targeting, one is physiology targeting. Okay. Ultimately, result is patient's pain relief. Individual agents for intervention that I will take later. First, let Dr. Devjyotish talk about the individual interventions. If you have any question, please tell me. So when you are just listening the lectures and all, just uh, try to think that these drug always this much you memorize from the whole lecture, that this drug is acting on which part of the pain pathway. Okay, so you will be writing the drug in a very logical way. Okay.
Hello, am I audible?
Yes. Yes.
Okay, so let me start with individual agents. So today I will be describing individual agents, commonly used groups that we use for the pain medicine apart from the analgesics and opioids are the pain adjuvants. These are not painkillers or analgesics, but they can modify the pain pathway and the perception of pain. So it has certain advantages over the conventional analgesics. First of all, in long-term pain setup, that means when the patient is having pain for long, there are certain conditions that is known as sensitization. That means the nerves which are there, they are getting sensitized and they increase the sensation of pain and the pain becomes long-standing. So they can block those pathways and make the patient pain-free for long. Being the group which are commonly given for longer period of time, these drugs are comparatively safer to use for a longer duration of time. The first group what we commonly use is the anticonvulsant group. Among the big list of anticonvulsant medications, immunostimulants, carbamazepine and oxcarbazepine, these are the very commonly used medication for the pain management. Among the aliphatic acid carboxylic acid group, there is valproic acid and divalproic sodium, which is commonly used for the migraine headache for the pain management. And including the cyclic GABA analogs, includes the gabapentin and pregabalin, they are commonly used for the neuropathic type of pain. And there are some newer drugs like topiramate, vigabatrin. We have also used certain kinds of pain, again in migraine as well. So these among these medications today I will be describing mainly four drugs: carbamazepine, oxcarbazepine, gabapentin, and pregabalin, which are most commonly used for the management of chronic pain. Now, as Dr. Rai has already discussed how these drugs are, they have the mainly membrane stabilizing properties by which they either can act on the sodium channel, they can act in a GABA mediated pathway, or they can act on the calcium channel. So ultimately, they will inhibit the polarization of the nerves so that pain transmission can be blocked. Or in some cases, they can mimic or enhance those pathways. For example, pregabalin and gabapentin, they do not act as a GABA agonist, They enhance the pathway on a calcium channel. So they are actually stabilizing the membrane, and that's why it is causing less depolarization and less sensation of pain. Coming to the first drug of today's discussion, that's carbamazepine. Carbamazepine is marketed structurally to imipramine, which is one of the antidepressant that is also used in pain, but not more as frequently as carbamazepine. It was first introduced in 1960 for the trigeminal neuralgia. Till date, it is the drug of choice for the trigeminal neuralgia pain. Its pharmacological action resembles phenytoin through its action on the sodium channel and prolongation of the inactivation state, so ultimately stabilizing the membrane, reducing the depolarization, and reducing the nerve conduction. It has also some lithium-like therapeutic effect. For that, it is having used for the bipolar disorder. It is not a point of discussion of ours today. Now it has some antidiuretic action, probably by enhancing the ADH action on the renal tubules. So in elderly age group, it can cause hyponatremia. So you have to be cautious in that regard. Now, coming to the dosage for uh, terminal neuralgia, we commonly use the dosage between 200 and 800 milligram. Usually, we start 100 milligram twice a day dose or a 200 milligram sustained release dose once a day. Gradually, we increase the dose up to 200 milligram or as long as the patient is able to tolerate this medicine. Now, coming to the pharmacokinetics, it is having slow and soluble oral absorption, poor water solubility, 75% bound to the plasma protein. What is more important is that its metabolism. It is metabolized by the cytochrome enzyme in the liver. Along with there is the hydroxylation and conjugation with the inactive metabolites. One of the most important thing regarding this metabolism is autoinduction. So it can induce its own metabolism by which the initial half of the carbamazepine is quite high. Once the drug is continued, the T half reduces because of this autoinduction of this enzyme. The half-life dynamics for the same. Initially it is 20 to 40 hours, but later reduces to 10 to 20 hours. Now coming to the adverse effects, it is very important. There are some adverse effects that are dose dependent. So we commonly get this adverse effect. The advantage is that by reducing the initial dose, you can have these effects very limited. For example, the sedation, dizziness, vertigo, diplopia, sometimes ataxia that might occur, so start with a lower dose. Next, higher dose, it can cause vomiting, diarrhea, odds and seizures. So in moderately high dose, this is one of the problems. In some patients, for this reason, we have to stop the drug as well. Acute intoxication, as we are giving in a very regulated manner, we do not encounter this acute intoxication more or less. What we encounter in some patients is the hypersensitive reaction. Okay. If it is only rash, photosensitivity, so that is okay. But in some patient, it can actually cause the toxic epidermal necrosis and the Stevens-Johnson syndrome. So we get good number of patients who have this allergy. So for this patient, you have to move with any other medication, and definitely you have to manage the condition for which the patient. Like I mean, in some patient, it might cause leukopenia because of the hypersensitivity. In elderly patient, I have already told it might cause water retention and hyponatremia, and there are increased risk of fetal malformation, so it cannot be used in a pregnant patient. Now coming to the indicated and off-label uses of carbamazepine, trigeminal neuralgia, it's the first-line treatment, diabetic neuropathy. In some cases, it may be considered post-herpetic neuralgia. It may be used. Off-label use, peripheral neuropathy, central neuropathic pain. Usually, we routinely do not use it as an off-label use. Now coming to the next drug, this is oxcarbamazepine. So it is an alternative to carbamazepine in trigeminal neuralgia. Rapidly metabolite converted to the active metabolite, and that metabolite undergoes glucuride conjugation, not oxidation. So avoid toxic effect associated with the epoxides of the carbamazepine. Now, drug interaction and autoinduction, it causes less autoinduction and weak enzyme inducer property, and with other drugs the interaction is also much less. It has the lower risk of toxicity compared to carbamazepine, higher risk of the hyponatremia compared to carbamazepine. Just 1 minute. Okay. So coming to the indications and tolerance. Indications is almost similar to
Jyoti,
carbamazepine.
Jyoti,
Yes, yes.
your audio is not good.
My audio is not good.
Others, do you feel
Like,
audio is okay?
just 1 minute. Let me check.
Yeah, others can get the audio
Please
right.
comment. It is a only local to Dr. Chinmara, or my audio is inaudible to everyone.
No, it's audible.
It's clear.
It's clear.
I'm taking the
Yeah,
mic closer to my mouth.
Okay then. Okay then. Mhm.
Okay. Now, is it better? Or previous? Oh, sorry.
I
Is it okay now?
yes, now it is okay. Mhm.
Okay, fine. So let's continue. Okay. So indications is similar to carbamazepine. It is comparatively better tolerated. So in some cases where we cannot use carbamazepine because of other contraindications, allergies, we can easily replace with the carbamazepine. And P-half is less than the carbamazepine. But what is the starting dose? Usually we start with 50 milligram thrice a day or 150 milligram sustained release preparation once a day. And gradually we can increase up to 600 milligram, very commonly we use. And if required, we can combine with the other medicines as well. Now coming to the gabapentin. Remember, probably these are the two drugs, gabapentin and pregabalin. It is most widely used for the management of the chronic pain. Now, gabapentin is a lipophilic GABA derivative which enhances the GABA release. Remember, gabapentin as a drug is not going to and, bind with the GABA receptor, but it binds with the alpha D2 type of calcium channel, and by which it potentiates the action of the GABA. And it is having the analgesic effect in the neuropathic pain. Gabapentin and pregabalin exerts a specific analgesic effect in the neuropathic pain conditions, and it modulates calcium channels. And there are some studies that have shown it is some action on the descending inhibitory pathway and some action on the these other receptors as well. But these claims are there, but they are not proved. Now coming to the clinical use, it's the first line of drug for the neuropathic pain conditions. Be it a post-herpetic neuralgia, diabetic neuropathy, so there are wide indications. Some are the real indications, some are off-label use, but in reality, a lot or number of conditions, gabapentin is commonly and widely used for the chronic pain. Now, this drug has a very peculiar property that undergoes absorption, and this absorption is not linear. So this is a little bit unpredictable absorption what we observe with the gabapentin, but pregabalin has better and more predictable absorption. Now it is treated unchanged in the urine. Both the drugs, gabapentin and pregabalin, they do not undergo any metabolism in the body, but they undergo unchanged in the urine. So in one type of cases, you should always remember reducing the dose of gabapentin when the patient is having compromise in the renal ground. Hence, the patient is having CRS, you should reduce the dose of the gabapentin. And the half-life is usually 6 hours. So, usually it is given in once, or if you are giving most commonly we use this first and release preparation. That's why we give once. Otherwise, it is given 3 times a day, most commonly. Now coming to the drug interaction, there are no significant drug interaction have been noticed with the gabapentin. No change in dose primary anti-epileptic drug is required when we are adding gabapentin with the regimen. And in pain also, it can easily combine with the other drugs like or antidepressants, so that they are having synergistic effect as they act at different levels. This is acting on the presynaptic calcium channels, and that is acting on the reuptake inhibition. So, in by this way, they can actually synergistically increase effect of the other drug without having any major interaction among those things. Now, coming to the dosage, usually we start with the 300 milligram either once a day, or you can go for 100 milligram 3 times a day, depending on the patient, and then gradually increase the dose to 300 to 600 milligram TDS. But in Indian patients, they usually do not tolerate more than 1200 milligram. So usually try to restrict that within 1200 milligram. But if you go for the books, it is written the maximum dosage is up to 3600 milligram, but we actually rarely can go up to that level for the Indian patients. But there are few important things regarding gabapentin. First of all, check the renal function. That is very vital. As I told, that is the only way by which gabapentin can go out of the body. Check the thyroid function because it may cause hyperthyroidism. And dose reduction is required in the renal impairment. Those should be titrated slowly according to the response and tolerability. And example, weekly 300 milligram intimate is usually or commonly done. There's potential for the abuse and dependence. So it could be supervised and prescribed medications only. The patient should be assessed for the suitability prior to the commencement of the treatment, and then gradually we have to increase the dosage. Common side effect is the sedation. Most of the patient complain of the sedation and they might have the tiredness, dizziness, unsteadiness. Few of those patients sometimes can complain of the edema, especially the peripheral edema that might occur. Though in this regard, pregabalin causes more peripheral edema than gabapentin, but the number of patients is comparatively less. Coming to the pregabalin. Pregabalin is newer conjugate of gabapentin. One of the biggest advantages that here the onset of action is rapid and the gabapentin, and its absorption is quite predictable, which is in contrast with the gabapentin. It shares similar pharmacodynamic and pharmacokinetic properties with the gabapentin, and clinical indications also overlap in between those. But as pregabalin is more researched, so they have got some other indications as well apart from gabapentin. Basically, it's a US FDA approval that all depends on the number of studies conducted. So it is utilized for the neuropathic pain conditions like diabetic neuropathy, post-herpetic neuralgia, for which gabapentin is also an approved drug. It is used for the complex regional pain syndrome, other chronic pain types. It can be used for the conditions like fibromyalgia. So that is the indication that is not there for the gabapentin. Though I have told the off-label use is always gabapentin has been used in the fibromyalgia with quite a good result. Now coming to the dosage, here usually pregabalin 75 milligram is equivalent to 300 milligram of the gabapentin. Usual starting dose is 75 milligram. Gradually, we increase the dose to 150 milligram twice a day, and we can go maximal up to 600 milligram per day. But for the Indian patient, usually we start a little lower dose like 50 milligram at bedtime. Gradually, we increase to up to 150 milligrams. Sometimes we have gone up to 300 milligrams, but that is when the patient is already taking the drug for long and patient is well tolerated with the medicine. So do not go for a very high dose from the beginning. Now coming to the side effect profile, it is claimed to be less prominent sedative side effect compared to the gabapentin, but personal my clinical experience is not telling so. It causes almost similar or sometimes more sedation than gabapentin. Though all the books it is written, it is causes less sedation. Potential side effects may include impaired concentration, rashes, peripheral edema, and weight gain. And so, peripheral edema and weight gain sometimes is observed more with the pregabalin. Now, it is having linear and predictable pharmacokinetics. Absorption is not affected by the food. Less variability between the patients compared to the gabapentin. So, that is the comparison between gabapentin and pregabalin. Bioavailability is higher. Mechanism, it binds with the central nervous system calcium channels and actually causes the accelerated neurotransmitter release more potential than gabapentin. Clinical causes approved for the fibromyalgia and the generalized anxiety disorder. This is there for the pregabalin but not there for the gabapentin. Now coming to the antidepressants, we have a big group of antidepressants, but not all the drugs are commonly used for the pain. Remember, for the pain management, it is more of the reuptake inhibition of the norepinephrine is important than the reuptake inhibition of the serotonin. Basically, it is a descending inhibitory pathway that goes from the periaqueductal gray matter to our dorsal horns. This inhibitory pathway, when they are actually stimulated, it causes less entry of the pain towards the central nervous system. So these drugs mostly act by those mechanisms. So, what is the difference between amitriptyline, nortriptyline, duloxetine, venlafaxine? Basically, these are the most commonly used antidepressants for the pain. Now, tricyclic antidepressants works on a wide variety of receptors, including the serotonin, noradrenaline, in sodium channel blocking, NMD antagonism. So these are the older compounds, also known as tricyclic antidepressants. Now, regarding amitriptyline and nortriptyline, both are used for the pain. It is said that the nortriptyline having a little better side effect profile than amitriptyline. Then SNRIs, basically, if we see the third generation antidepressants, mainly the SSRIs and SNRIs, among those medications, what differs is the ratio of the reuptake inhibition between the serotonin and norepinephrine. Duloxetine is more selective towards serotonin, but the ratio is very low. That means it is only 3:1. That means it is 3 times more potent over the serotonin than norepinephrine. So again, for the pain, drugs are acting mostly depending on the reuptake inhibition of the norepinephrine. Similarly, there is another medication that is known as the milnacipran, which is having more effect. That is it is doubly selective towards the norepinephrine than the serotonin. So that is the ratio difference. That is why these drugs are more commonly used for the pain rather than the SSRIs. SSRIs are having the less side effects and have the better mood elevators. Now, regarding the amitriptyline, first of all, start low, go slow. Begin with 10 milligram at bedtime, and remember, dose that is used for the depression is much higher than the dose of the pain management. So what happens? Usually, we do not get the side effects what is commonly get by the psychiatrist. In fact, in depression, it is commonly given 100 to 150 milligram, but for the pain, we usually use up to 50 milligram. Okay. Means the common dose is 10 milligram at bedtime, and gradually increase up to 25 or 50 milligram. Okay, and we have to adjust the dose according to the response. Usually 10 milligram increment weekly we do, and depend on the condition, and we have to reduce the dose if there is oversedation or the patient is having other side effects. One of the common side effect is the anticholinergic effect like dryness of mouth. If the patient is having BHP, that might decrease the maturation because of the anticholinergic effects. Now maximum doses 100 milligram at night, limited benefit beyond 50 milligram when increase the side effects. Okay. And coming to the contraindication. So, as I told, gabapentin might cause arrhythmia, and the most common side effect, a type of arrhythmia that is produced is the sinus arrhythmia. So, it is contraindicated if the patient is having arrhythmia or patient is having the post-myocardial infarction recovery phase. You have to be careful in certain conditions like elderly patient, patients with the glaucoma, prostatic hypertrophy, cardiovascular disease. And regarding the safety, exercise caution to the patients who drive or operate machinery because it can cause sedation. If there is no response within 4 to 6 weeks after giving the drug, you should withdraw it gradually. Now, regarding these antidepressants and SNRIs, we have to remember one thing, that is the serotonin syndrome. Remember, it's a very rare condition, but we should not forget because sometimes in the pain, the patient is having other drugs, like the patient is having tramadol or tapentadol that also acts on the serotonergic pathway. So they also does the reuptake inhibition for the serotonin. If sometimes the SSRIs, SNRIs, and tramadol they are given in combination, they can cause a large rise of the serotonin in the descending pathway, which leads to a condition that is known as the serotonin syndrome, which is associated with the agitation, confusion, rapid heart rate, increase in the blood pressure, sweating, tremor, diarrhea, fever. So, if this sort of patients we are getting, so there is no specific management. You have to manage symptomatically, but what you have to do immediately stop those drugs. That is very, very important. Now, coming to the duloxetine. Duloxetine is having proved indication. Remember, this is a newer development that now it is licensed for the osteoarthritic pain management as well, especially for the chronic osteoarthritic knee pain. We commonly prescribe duloxetine. It's a US FDA approved um, indication where it can really reduce pain of this degenerative condition. It is used for the diabetic neuropathy, peripheral neuropathy. It is used for the fibromyalgia. All are the approved indications. Recommended dosage is 60 to 120 milligram, but usually we go from the lower dose as all the antidepressant is given at a comparatively lower dose for the pain. So recommended dosage is starting dose 20 milligram at bedtime, gradually increase to up to 60 milligram. That is up to that level. We usually commonly go for the pain. But if the patient is not responding, you can go up to 120 milligrams. That is the maximum dosage in the diabetic neuropathy. So begin with these are for Western protocols. India, I have already told, we go a lower dose and we have to, depending on the response, we have to monitor. And it is not recommended for the patient with a liver disease. And if there is severe renal impairment, this drug should be avoided. Now we have a lot of adverse effect with the duloxetine, like nausea, vomiting, dry mouth, headache, then fatigueness, drowsiness, insomnia, dizziness, lightheadedness, depressed appetite, weight loss, sexual dysfunction, sweating, increased blood pressure, and septic syndrome. These are overall range of side effects, but the most common side effects for which the patient says are the first three. That means nausea, vomiting, sometimes dry mouth, though it is more with the amitriptyline, and sometimes headache, fatigue, drowsiness, insomnia, dizziness, or lightheadedness. So that might occur. These are the common problems that patient complain when the patient are coming for the first time or they are starting the medicine for the first time. So only way for those conditions, these are not life-threatening or life nothing to worry. You have to just reduce the dose and then continue and gradually increase. In most of the patient, this strategy works very well. Coming to the capsaicin, it's a newer dead drug that is actually used on the TRPV1 activation. So TRPV1 is a type of receptor which is known as the transient receptor potential cation channel subfamily 5 member 1. So basically when these are activated for a long time, initially it causes heat, some acidosis and the endogenous agonist. So it increases the sensitivity. But when it is used for the longer duration of time. If you put the capsaicin for first, it will cause heat, burning, stinging, itching, but keep it there. After sometimes you will feel analgesia at this point. Okay? And this area becomes less responsive to stimuli. That is why it is most commonly used in a lot of preparations like the pain this ointments. Okay. So it is also approved for the use in painful diabetic neuropathy and the post-diabetic neuralgia, recommended for the localized neuropathic pain when the oral treatments are contraindicated or are not tolerated. Strength of 0.0 to 5% strength used for the osteoarthritic pain, but not indicated for the neuropathic pain. So application, take a very small amount and just put it over the area of the pain. So it is a type of local action only. Avoid in patient ask the patient wash the hands and immediately after the application avoid using in the Brucan spring. Okay, if the patient is not responding even after 1 month of use, you should discontinue the drug if there is no benefit. So these are the most common pain adjuvants, but there are some specific drugs that will come when we'll be discussing the specific topics. So any question regarding this? Otherwise, I will move for the neurolysis part. No questions. Okay, fine. So regarding neurolysis, let's discuss a little regarding the neurolysis. Now, neurolysis means suppose there is a point A, which is the receptor, and there is a point B, which is actually the area where it is sensitizing. In between, there is the wire, and you can think of it is the nerve. If we can block somewhere in the pathway, what will happen? The pain that is originating from one area, that is pain generator, it will not travel to the central nervous system, and ultimately that will cause reduction of pain. So what could be the mechanism? By any way, we have to dampen the nerves at that level. For example, say we are having a pain in the facet joint, that means the joint and the back. So from that joint, the pain is coming to our head, and ultimately it is causing the sensation of the pain. If we can block the nerve supply of the facet joint, which is the median branch, we will no pain. On the basis of this concept, we have started neurolysis technique. Now, in neurolysis, drugs which have been used for long time are the chemical neurolytics. Among those chemical neurolytics, most commonly used compounds are the alcohol, phenol, and the glycerol. Remember, glycerol is a very selective neurolysis. It do not act in other areas. It is mostly acting in the trigeminal neuralgia only. So, in the gastrin ganglion, we can block with the glycerol. What other areas are suitable for the neurolysis? Like celiac plexus, that is sympathetic plexus, where we can use alcohol and phenol. Now, I am not going in much detail of these two drugs, alcohol or phenol. But we should know the most important 2 3 points. First of all, concentration of use. We use the alcohol at a concentration in between 50 to 90%. Regarding alcohol, we should remember another very important point. Do not inject alcohol first in the nerve because it will cause a severe burning sensation. So we have to use local anesthetic first, then we have to give alcohol. Number three, after giving alcohol, you should not just pull the needle. You have to inject a very small amount of the local anesthetic to avoid the tract formation, and then we have to pull the needle. Okay? These are very important points regarding the alcohol use. Though these drugs are not commonly used nowadays, except for few situations like the celiac plexus and the superior hypogastric plexus, where we can not do the modern day techniques like the radiofrequency or ablation. This is why it is still used there. Regarding phenol, one thing you should remember, do not expose the patient's skin with phenol because it is having the irritant property, it can cause burn in the skin. So whenever injecting the phenol, you should always put the uh, saline soaked gauze over the skin, cover it, then inject the phenol. By that there is accidental spillage, it will not come into contact with the patient's skin. These two things are very, very important for phenol. Now, regarding the another important point, phenol is not available pre-made in the market, so you have to made it in your hospital pharmacy. And usual concentration at which phenol is used is between 5 to 6%, and 5.8% is the saturation point of phenol in normal saline or water. So that is 30 degrees Celsius. So if we can mix phenol crystal at 30 degrees Celsius, we can make a saturated solution. So that comes 5.8%, and that is good for the use in the patients. Now, regarding alcohol and phenol, the duration of pain relief is more with the alcohol, the duration of pain relief is slightly less with the phenol. But both are can be used. But there is one condition that is important and that occurs with the alcohol is alcoholic neuritis. So what happens? There, if the alcohol is used in a somatic fiber, if there is partial destruction of the fibers, then even after neurolysis, this partial destructed fibers can create ectopic signals. So they can cause deafferentiation pains, and this is the pain which is occurring at the area of the numbness. It is do not that is common with alcohol, but do not occur with the phenol. So in that way, phenol is safer because these complications do not have there with the phenol. Now, another important thing is that phenol itself is having local anesthetic-like activity. So, with alcohol, prior to injection of the alcohol, you have to inject normal saline. But for phenol, you do not need to inject the normal saline prior to injection of the phenol. So, I think this small discussion between the alcohol and phenol you have understood. Next, I am moving to the glycerol. Glycerol is the agent I have told you acts by dehydration and it acts only in the Castrian ganglion. So it is used for the
Devjyoti, you are not
acid.
showing it. Devjyoti, you are not showing any PPT, na?
Now I am just discussing about these two drugs. When I will come to the radio frequency, I will show the PPT and the video as well. So I'm just highlighting on the important points because you have to know these points, but these points are not commonly used nowadays. Okay, so as a pain physician, you should know what is done prior, in which conditions still we use these drugs. But as they are not in routine use, I'm not going into details of this. Now, regarding the glycerol, one important point is the concentration. It is given in between 90 to 100% of the concentration. Usually, it's a very viscous fluid, and you take 99.9% of the glycerol and then dilute it with normal saline slightly so that make it easy for the injection. Otherwise, it's so viscous, it is very difficult. And at the trigeminal ganglion, you have to give in very small amount, usually 0.1 to 0.5 ml, it is good enough. So, in the advanced course, when we'll be discussing the trigeminal neuralgia and all its management, we'll be coming phenol again and again. But phenol is having an advantage, but it doesn't having this deafferentiation pain like alcohol, and it is quite safe for the trigeminal neuralgia. it cannot be used in other areas. So that is about the phenol. Now let us move towards the today's neuroablation technique. That is mostly today we perform two, three procedures. One is the conventional radio frequency. Next is the pulse radio frequency. Third one is the full radio frequency, and fourth one is the cannulation. So these are the four techniques nowadays widely used for the neurolysis. So I'm just opening the slide for those details. Okay. So as I told, there are ways of neurolysis like surgery, chemical neurolysis, thermal neurolysis, cold lesion, and mechanical compression. So these are the all ways of the neurolysis. Neurolysis gives advantage of long-term pain relief, no side effect from the drugs, and in long run, it is also cost effective. I'm not going into the details of this mechanism, what I have already discussed. Okay, let's move to the radio frequency. It is very important. So, what is radio frequency? Radio frequency is basically we are making an electric circuit. Okay, like this. One, this is the radio frequency generator, where the normal domestic current, which is having 50 hertz alternating frequency, which comes to this machine. The machine converts this normal electrical frequency, 50 hertz current, to 300 to 400 kilohertz of electricity. That means this alternations of the alternating current we are increasing. Why we are increasing? Because in between 50 to 60 hertz, it is the most physiologic current, like your nerve stimulation that happens in 50 hertz, your cardiac stimulation that happens at 50 hertz. If you want to hit the needle with 50 hertz current, ultimately patient will die in shock, or he will be having convulsion because of the neurostimulation. So we are increasing the frequency to at a high level, which are non-physiologic current, so that it will produce the heat at the needle tip, but it will not cause any other physiological effect of the current. So these are very important MCQ points, that what are the normal frequency for the nerve stimulation, what are the normal frequency, what are the radio frequency frequencies. Now this machine has certain important things, among which it is having the radio frequency current generator. There is one ground pad that we have to current with the patient's leg to the machine. This is for the returning current. And here we have to put the probe, which is having a small electrode at the top. Okay. And this probe we have to pass through a cannula to the target. Target means here it's a nerve, where we have to block through the radio frequency. We have to put deep there. After putting there, we have to start the current. Current is in a very measured way, and this current will generate heat. But before giving this current, we have to do two important things. One is the sensory stimulation, and other is the motor stimulation. Means to be sure we are close to a nerve, we have to do three things. One, we have to put the needle close to the nerve with the help of some image guidance. Either it is done through fluoroscopy or ultrasound, depending on the area where you are doing. If you are doing for the small nerves of the knee joint, it can be as it is very superficial, can be done with ultrasound. If you are doing for the spinal nerves like a facet joint, it is commonly done with fluoroscopy because it is deep and where placement through fluoroscopy is easier. So first thing, we are using this guide. Number two, what you are using? You are doing a sensory stimulation by 50 hertz and 0.5 volt of current. 50 hertz is the number of stimulations and 0.5 volt is the voltage of current what we are giving over the nerve. So if it causes paresthesia at area of pain, we understand we have on the correct nerves, because the nerve that is carrying the pain, we are trying to block that nerve. So once the paresthesia we are getting after the sensory stimulation over that area of the pain, we are sure we are at the correct position. Regarding the motor stimulation, there are two rules. It is done in 2 hertz of electricity current, and it is done in 2 volts. So what happens? In 2 hertz and 2 volt current basically stimulates the motor nerve, where we are actually ablating a motor nerve like a or mixed nerve. We do not ablate a purely motor nerve, rather we sometimes a mixed nerve like a median branch of the facet, where we are actually seeing the multifidus contraction. So we know that this nerve is supplying the facet joint and the multifidus. So there will be multifidus contraction here if I am over the correct nerve. It should not cross the contraction of the muscles in the leg. So that is the important point here. Okay. So these are the main principles of RNA. So you can take a picture of this slide as well. So there is a thermocouple probe through which the current passes to the body. But remember, this probe is not heated by itself. It actually dissipates the heat generated by the surrounding tissue. So what happens? Because of the flow of the current, the water molecules around the tip of the needle, they moves to and fro because of that high frequency. So that collides with the other molecules, and due to friction, the heat generation of heat is there. So the heat is actually generated by the tissue around the tip, but that heat is measured by our machine, and we can control the heat. Usually, in a conventional radio frequency, the lesion what is generated around the tip is usually the size of 2 to 4 millimeter. And beyond 2 to 4 millimeter distance, the electrical field is so weak to produce a visible lesion. The tip temperature we can set between 65 to 90 degrees Celsius, depending on the area where we need to do the ablation. That we'll discuss when we will be discussing the specific areas in the pain management. Now, how the tip temperature is controlled? It is controlled by reducing the electric current or by stopping it. So, in conventional radio frequency, the current is reduced, but it is continuous. In pulsed radio frequency, the heat is controlled to 42 degrees Celsius by giving pulsed electric currents. There will be a gap and there will be certain pulses. But remember, pulsed radio frequency is a completely new technology, and action is the neuromodulation. Pulsed radio frequency do not causes any neuroablation. So what I am telling you are the most important points in radio frequency. Okay, remember, in pulsed radio frequency, we are putting the probe close to a nerve, but we are keeping tip temperature up to 42 degrees Celsius. That cannot produce any lesion. But we are giving pulses of current and very high burst. So they actually causes neuromodulation and reduces the pain. So that is the concept of pulsed radio frequency. And this invention happened when the scientists have seen in certain conditions, but in a very low temperature, what is not able to produce any emission, they can reduce the pain. So that is why this new modality has been invented. So in pulsed radio frequency, if we use a pulsed mode, this phenomenon will happen. There will be some pulses and there will be some gaps. Usually is 20 millisecond the pulse, and there is 480 millisecond of gap in between. And this you should always remember this shape, that at the tip, the lesion is very less, but at the shaft, the lesion is more in case of conventional radio frequency. At the pulse radio frequency, more happens, electrical field and magnetic field occurs at the tip, for which for pulse radio frequency, the way you should keep the needle tip is something a little different than the conventional radio frequency. Okay? In conventional radio frequency, we will try to keep the needle like this. If this is the nerve, we should try to keep the shaft close to the nerve. So it should lesion should encompass this nerve. So the big difference between the pulse and conventional radio frequency, pulse do not produces any heat lesion. Pulse temperature is fixed at 40 degrees Celsius, but pulse are given in the punch so that there is modulation in the nerves. There are a lot of theories, like some says there are some gene expression. Nothing is proved. So we do not know what is the exact mechanism, but it is proved that it can reduce the pain if it is the pulse radio frequency. So in some areas where the blocking the nerve is very safe, like a knee joint, or like in case of facet joint, or like trigeminal neuralgia, we should always use the conventional radio frequency when we are having a very important motor nerve, say suprascapular nerve. It is supplying our supraspinatus and infraspinatus. So if you have to do lesioning at the supraspinatus, so sorry, not suprascapular nerves, so we have to go for pulse stimulation because it will reduce the pain without the blocking of the motor function. So that is very important parameter for the pulse radio frequency. But only problem is that failure rate of the pulse radio frequency is comparatively high. There is no differentiation pain which may sometimes occur even after a conventional radiofrequency, though the incidence is much, much less than alcoholic neuronitis. So this are the comparison, and always before doing, the patient will ask, sir, how much relief I can expect for a conventional radiofrequency. We usually say the pain-free period might last from 1 year to 5 years if properly done, and average it goes up to 3 to 4 years. Whereas in pulse radiofrequency, it is usually 4 months to 24 months. So it is much less in pulse radiofrequency than the conventional radiofrequency. Now, if you have understood these two concepts of the conventional radio frequency and pulse radio frequency, we'll move to the cooled radio frequency. Cooled radio frequency is a technique by which we are actually cooling the tip of the probe to make the lesion size larger. I will not go into the details of the physics because will take a long time, but it causes a spherical large lesion because of the cooling with the channels. In the conventional radio frequency, we have a probe, we have a cannula. But here we have a cannula through which water can pass and make the needle tip low temperature. And remember, cool radio frequency is commonly done at 60 degrees Celsius so that the inner core will go up to 80 degrees Celsius, but this heat distribution will be slightly different, and there will be the central needle which will be giving the electric current, that around that will be flowing the water and we will be cooling the tip of a conventional radio frequency. That is why it is called cool radio frequency. But remember, it is also a positive temperature and heat lesion. It is not a cold lesion. Cold lesion, it is done in cryo. This is cool has certain advantages. First of all, it causes a big lesion. So in areas where the nerve location is difficult. For example, sacroiliac joint. There are a lot of nerve passing from different angles. So we cannot precisely go over the nerve. So we can make larger lesions and we can get hold of all the nerves to block. So that is the biggest advantage of the cooled radio frequency. That is a term you might encounter is the bipolar radio frequency. Concept is similar to the conventional radio frequency. But here, instead of giving a ground pad, two needles are placed close to the area where we need to be heated. So we have to pass the current from one to the other, and that will cause a larger type of lesion. So basically, these are all techniques, cool radio frequency, bipolar radio frequency techniques to increase the lesion size. So there is a multi-channel. I am not going to the multi-channel. Multi-channel is similar, but instead of one probe, there are more probes. That's all. And this is our cannulas. Usually, we first put these cannulas, they are similar to the spinal needles, but it is having an active tip which around which the heating is occurred. Then we have insulated stem, and it is available in different active tip size and different length. Usually, it is available in three main length: 5 centimeter, 10 centimeter, and 15 centimeter. And the active tip goes from 2 millimeter to 15 millimeter, depending on the disease. When we will be discussing with the disease, we will be talking which to use in which cases. And some are straight, some are curved. Curved is little bit easy to maneuver, so most of the people use curved one. These are the newer cannulas. I think this is not required for the basic course. So these are the type of lesion. So in case of conventional radio frequency, the lesion will be like this. In case of cooled radio frequency, the lesion will be like this. In case of the bipolar, the lesion will be like this. Now, two important parameters. That means there is a set time and set temperature. Beyond that, there is no lesion increase. That means it is said that if we lesion up to 90 seconds, that is optimal. Beyond 90 seconds, if you go and doing radio frequency for 5 minutes, 10 minutes, it will not increase the size, because once it reaches the thermal equilibrium, it cannot increase. Similar for the heating, we cannot go beyond 90 degrees Celsius, because it's close to an hour, we go beyond 90 degrees Celsius, water will start evaporating and the hydrocarbon of the tissues will be charred. So ultimately, lesion will not be produced around an hour. So maximum temperature what we can go is to 90 degrees Celsius. To increase the lesion size, these are the techniques. So using a larger, thicker needle, increasing time up to certain level, so that it will not increase. using cooled RF, using the bipolar RF and newer cannulas that I have not discussed. So always remember, before putting, we have to do and check the following things. Check the confirmation. Use image guidance, use sensory testing, do motor testing. And another important thing I should always say, remember that check the impedance. Impedance is nothing but the resistance in the circuit. If the needle tip is accidentally inside a fluid, so what will happen? The resistance will decrease. So if it is inside CSF, then the impedance will come under 200. So you will be able to understand that my needle is not in perfect position. I have to reposition the needle. And similarly, if it happens that it is quite high, that means you are inside a fat or inside a bone. Okay. In that way, we have modified. Now, there are a lot of indications of the conventional radio frequency. I'm not going into details. So, the accident ganglion is really one of those we commonly use. There's splanchnic, lumbar sympathetic. These are common use. And with use of these conditions, when we'll be discussing. Pulse is, I have told, when we are going for a mixed nerve, it is the pulse is the choice. And important motor muscle, what is it is when important what when it is giving supply to an important muscle, then we use pulse radio frequency. Similarly, we should use the cool radio frequency where the localizing the nerve is a little bit difficult, be it the shoulder, hip, genicular branch of the knee, sacroiliac joint, and lumbar facet. Sometimes we can use, but I prefer the conventional one. Bipolar is also having the same indication. Actually, before the cool RF, bipolar was used in those conditions while now cooled is used. So that was overview of the conventional radio frequency. Okay. The cryoanalysis we will be discussing in the advanced course. And just I will be showing a video, a very small video to describe the machine. Just 1 minute. Let me start the video. Okay. I think I have to switch on the shared sound. Sound shared, sound shared. Share sound. I got it. So this
is this one.
can
This is
share the
the
video sound or
radio
not.
frequency we put at the target. This is a very fine needle and it has two functions. One is the supplying the electricity to the probe, to the tissues, and to measure the tissue temperature. Because one thing you should note, the tissue is primarily heated because of the radio frequency current, and that current is being first transmitted to the radio frequency needle, which so it goes first inside
And
this
inside the video
and then
sound,
it is heated. So it should go inside this
Imada,
radio frequency cannula
is it
or
audible?
radio frequency needle.
Yes.
So this is one of the most important thing. This is the upper portion. You should put it inside the side X before doing the procedure, and this is the connector part. This connector part gets attached with the radio frequency machine. These are the cannulas. So this is one, this is one, this one is the 15 centimeter one, this one is the 10 centimeter one, but it has a covered shaft as well as an active tip. So we have to say three parameters while describing a radio frequency needle. One is the length. What is the length? That is the 10 centimeter for here. Then we have the active tip length. It is here 5 millimeter. We can have 5 to 15 millimeters. Sometimes 2 millimeter is also available. So 2 to 15 millimeter of active tip. And we have the gauge of this needle. Okay, this is 22 gauge. So we have this radio frequency needle. So you can see it is 22 gauge and 100 millimeter. That means 10 centimeter. And active tip, you can see it is 5 millimeter. So this is most commonly used for the radio frequency ablation for the trigeminal neuralgia. This is another one. Here we have a 15 centimeter electrode. This is also having a 5 millimeter active tip, and this is 200 sorry, not 200, it is 20 gauge, and that is commonly used in case of facet joints, 5 to 10 millimeter active tip. This is the electrode. It attached with the machine with the help of these wires, and this actually completes the circuit. So let us do a radio frequency in the egg. So the last one, let us say connecting wire, and what we need to do, we need to first put this connector at this port, and this is a connector which actually attaches together. So we have to, by seeing which side it is, we have to connect this. So now this probe is ready for action. Machine has also detected it. Next thing what we are going to do is having this ground pad. Okay, we'll attach the ground pad. So for the attachment of the ground pad, we have to first attach this end to this port and the ground pad itself. Here we'll be attaching the ground pad, other end. First open this. So this connectivity or connections will actually vary from machine to machine. I am showing you this one, but it might be different in different machines. But once you know one standard form, then knowing the other one is not difficult. So I am putting a bowl in which I am putting an egg. So we can see the egg protein coagulation with the help of radio frequency. So let's see the last part of the video. Lesioning over the egg albumin, you will be able to see the lesion. So here I have put the egg. So you can see the egg yolk and egg white, and this is the radio frequency needle. Okay. So in this needle, this is the 10 millimeter active tip, and this is the lower portion of the needle. So let's first, what is our job? Is to put the thermocouple inside so that the circuit will be completed. So first what we do, we put this needle in the desired area, and then we take out this stellate from the needle. Now once we take out this stellate, then we should put the thermocouple probe. So here I am first holding the thermocouple probe. It actually completes the circuit. See, when I am removing this, the start mode is not showing, but as I am putting this, you can see the start mode. Okay, so we can see all the modes now. This is the stimulation mode. So here we can see the resistance. It is 127 ohm, and here we can see the temperature also. This is the temperature of the needle tip is now 31 degrees. I'm just interrupting a little within the video. Is that here what is happening? One thing I have mentioned but will not describe to you much is the resistance, because the invert of the resistance that is won by the resistor becomes the impedance, and this impedance is an important parameter for your needle placement. Usually it should be in between 300 to 400 ohms. If it is below 200, then it is signifies that it is inside a fluid. Say in case of trigeminal neuralgia, you are getting the value below 200. It signifies you are already in the fifth tract, or you are close to a vessel. So in those cases, you have to reposition. Okay, and if it is inside a fatty tissue or bone, it is very high, around 1000. And here also, there will not be any effective lesion generation. And nowadays, the machines are such that it actually guides that whether you are able to generate or not. It will show it's too high impedance or too low impedance. Then by that way, it will show. Okay, let's continue with the video. The Celsius, that is the room temperature. Okay, and it also shows the impedance here at this point. Okay, So it is around 83, but as it is liquid, it is less. But in patients, it should be higher. So first job in a patient is we need to go for the sensory and motor stimulation. So this is the motor one. So we have to first start, then we have to gradually increase the current. So you can see the current is increasing. This is the ampere. This is the impedance, and this is the voltage. Okay. So for it is hertz, how many impulse it will give is fixed. It is 2 hertz, and here it is actually written 2 hertz, and here it is the voltage. Usually for the most of the patients, the stimulation parameter for the motor is usually 1 to 2 volt and 2 hertz. Okay, but sometimes if the sensory stimulation you are getting at a lower voltage, you can get this thing, matlab you can get the motor stimulation even in lower voltage. Your means it is very close to the nerve. Now we are stopping. So we need to check the motor stimulation, and we need to check the sensory stimulation as well. In sensory stimulation, it actually shows the voltage you have to increase. So usually 0.5 and 50. That means 50 hertz and 0.5 volt is the usual stimulation parameter. So usually you have to go up to this, up to 0.5 volt and 50 hertz. But in neuropathic nerves, sometimes you have to increase it slightly. So that is the stimulation part. Now for the thermal radio frequency, let us show you the parameters. First we need to set. Here I have set at 80 degrees Celsius. This usually we set time duration at 1 or 2 minutes. Ideal should be 90 seconds. So here we can see the impedance. It is set temperature. This is the duration, and you can see this is the impedance. The ideal impedance while doing radio frequency, it is depends on area what you are doing, but usually 300 to 400 ohms. Now this is monopolar electrode. Now we are starting the stimulation. So let's start the radio frequency ablation. So we are starting the ablation, and you carefully note the.
Hello. हाँ,
Let me focus closely.
अच्छा ठीक है.
Hold it. और भीतर ही छड़ी देना. I'm making it closer so that you can see what is happening there. You can see at the needle tip there are a protein coagulation is happening. See, around the tip you are getting 2 to 4 millimeter of protein coagulation at the needle tip. Let us see the monitor what it is showing. So okay, so here it is showing the heat curve. Heat is right now at 80 degrees Celsius. The tip temperature has reached the 80 degrees Celsius mark. It is around 1.4 volt and 3.9 watt, and it is at 80 degrees Celsius. It will keep there at set temperature, that is 2 minutes, and they will stop after 2 minutes automatically. So let us see again. See, initially when there is generation of the heat, the lesion size, what is happened with time, it is not increasing. Basically, if you increase it more than 90 seconds, there is no point, because then it reaches an equilibrium where it doesn't increase the temperature further. So you can see the lesion, but with time, see, now lesion size is not increased. So one important thing is that up to a certain level, that means usually initially if you raise the temperature, it will automatically raise. Now it is stopped, so you can see the temperature is now decreasing gradually. So 2 minutes is over, and now the temperature is being decreased, and you can see the full-fledged lesion size at the needle tip.
So I think you have understood the lesion, radio frequency. So as the time is very limited, so right now I am not taking any further questions. 1, 2. If you have, you can put in the chat box. Okay. I think we have very limited time. Chinmay, you can start.
Okay. So just few more minutes. Sure. Okay. So here, we already talked about, Dr. Devjyoti has talked about this thing, no, that RF is mainly for ablation part. So I told that there is for our pain generator, we can regenerate the structure also, and we can take care of the inflammation also. So just see, this is the steroid thing. So steroid we want to give for inflammation part. We do not, if there is an inflammation in the pain generator, we want to take care of that. So we can inject steroids. So here, one important thing is, as ultimately it is the prostaglandin we want to stop. But then this is the mechanism of steroid. Here, there are some additional mechanism also, like it reduces spontaneous discharges in adjoint nerve, which reduces neuropathic pain and all. So these are extra advantage. Now, for a pain physician, the most important question, that advantage of injectable steroid, you will see the same disease. If the patient goes to a neurologist, they most of the time write oral steroid. So but we prefer injectable steroid. Why? With our intervention, mainly of course it is about the pain interventions I'm talking about. So then the one advantage is the side effect, much less side effect, because we are not we are not giving in blood that some amount will go in the right place and others in the systemic circulation. Of course, our injection also, our steroid also will be absorbed in the systemic circulation, but we are targeting the area. If there is a inflammation in the nerve, we are targeting the specific area. So lower liver toxicity, or say other side effects are also less. Longer cycles. Most of the steroid what we use is depot preparation, not the normal preparation. So these preparations are, once you have given the steroid, it stays in that position, that area for say 2 to 3 weeks. It can stay there. So we want to treat a chronic pain. So in that case, a bit longer effect is needed. Now, lower risk of side effects, as I told. Now, one very important question is particulate steroid and non-particulate steroid. This is very important for us. We are injecting the steroid inside patient's body. Now, we are injecting under X-ray or under ultrasound, inadvertently it can happen that we have injected the drug inside a vessel, and it can be an artery also. So there has been multiple cases till now, then that patient has developed different complications. If it is an artery, then patient can get infarct, or otherwise also embolus. It will work as an embolus, and patient can have multiple types of damage. So this is a major question: particulate and non-particulate. So which drug causes problem, which can form the emboli? So what are those? Those are called particulate steroid. Now mainly methylprednisolone acetate and triamcinolone, they are in most of the pain physicians use these two particulate steroids. Why do we use them? Because they have longer duration of action, and of course a longer time of application, you can say. This is the conventionally this has been used for a longer duration, for many years. Okay, so these are particulate steroids, but after the complications and all, it has been now recommended that don't use these particulate steroids in cervical areas or more vascular areas. You can use still you can use them in the lumbar areas, okay, but not in the cervical areas. And so what will you use in the cervical areas? So there you use non-particulate steroids, that is dexamethasone sodium phosphate, and betamethasone is also there, a preparation is there, but we are most of the time using dexamethasone sodium. So this is the, wherever you feel that, okay, mainly by, if we go by guidelines, then cervical area it is dexamethasone, and lumbar area we still use methylprednisolone acetate and triamcinolone acetonide. So we can use, but remember there is a great possibility that always you should see that your injection must not be vascular. Okay, so under X-ray, when we are doing the procedure, we are giving contrast and just ruling out that we are not in any vessel. Dose limit of steroid, no universally accepted limit. Mainly, important is spacing between interventions is important. So, though this spacing is also not fixed globally, but at least after one intervention, another intervention should not be done within 1 month. More than 1 month is must. Okay, so and in a practical scenario in clinics, we do not do a second intervention before 3 months actually. So minimum effective dose is advised. That is also important for one radicular pain. 20 mg one, or if we are targeting one area of injection, one for radiculopathy, say L5 radiculopathy, there is a small disc compressing the L5 nerve. Only 20 mg methylprednisolone is sufficient. There is no need to give 80 mg because that much is there in the vial. So that is what. Now another drug is dextrose prolotherapy. As I told you, we can take care of inflammation, we can try to regenerate. So these dextrose prolotherapy means it has come from proliferation. So prolotherapy means proliferation therapy. So here there is degeneration, we want to regenerate. So there are multiple drugs by dextrose also, and ozone also, and other like PRP, platelet rich plasma. We try to regenerate. So here, there are multiple systemic reviews and meta-analysis are there. There are evidences that dextrose prolotherapy is supported for treatment of tendinopathies, knee and finger joint OA and all. So you can go for mainly I will say it is for tendinopathies. It is a very good drug for regeneration. Okay, and so dextrose prolotherapy is more effective in the treatment of chronic pain compared to saline injection or exercise. So I'm not going in detail, but then hypertonic dextrose injections, like 5% to 25% people have used. Okay, so it is not fixed globally that you have to use say 10% or 15%. People have used 5 to 25%. Commonly, we are using 10% of 5% dextrose. 10% of dextrose I am using, and volume will depend on the area where you are injecting. So in a joint, you can go for 5 ml, 10 ml, not 10 ml, 5 ml to 7 ml, like you can use. But then if it is a tendinopathy, only 2 ml sometimes is sufficient. So modulation of the, what it does, it also does the modulation of the inflammatory process, and it restarts the inflammation. So it has to work. What happens, the main background theory is, after an injury, inflammation should occur and healing should occur. Like normal structure should replace a structure. Okay, but it can go in two different directions. One is it has been replaced, but with a weak structure, weak tissue, and not normal, abnormal tissue. So this is one pathway. Another pathway, a stalled inflammation. Inflammation after some steps, it has stopped. It is not going forward. Okay, so you can again you can do something which restarts the normal inflammation. So in these cases, when again inflammation starts, patient gets some more pain actually, and you cannot give those drugs which are anti-inflammatory. So that time you have, if there is a pain, you have to go for tramadol, paracetamol type of drug. Anti-inflammatory drug you will not give, and patient can have some increased pain locally. So then you go for other things like ice compression and all, and other medications. So ultimately, the theory is restart the inflammation. There are multiple theories. There are multiple theories and multiple effects. It is for regeneration therapy. Okay, and local pain, local infection. So these are there, and these are the like ideal concentration. 5 to 25% is, and 2 to 10 ml volume is people have tried. So you can go for some in between. PRP. So this is also a drug which is most of the time used, very commonly used for proliferative therapy. In my clinical practice, I will vouch for the tendinopathies. In tendinopathy, this works very nicely. Okay, in joints, I personally do not have that good experience that PRP really does that good or not. But in tendinopathies, it does very good response I have got. So PRP, what it does mainly, remember, in blood there is RBC, WBC, platelet, and plasma. In RBC, WBC, platelet, there is a platelet part which is less than 1%. In platelet part, there are multiple parts like lysosomes, dense granule, alpha granule. In alpha granule, there is some component which is called growth factor. So we are actually interested in growth factor, which is there in alpha granule, which is there in platelet is there in blood. Okay, so these growth factors are important for us. Of course, there are some positive effects of serotonin, epinephrine, histamine. As I told you, these are inhibitory neurotransmitters, so they have some effect. Okay. Some good effect, but mainly our target, we want the good effects of growth factor. So remember, in PRP we want growth factor to work, and of course it also modulates inflammation. So you see, PRP is not a new drug from 1970. It is being used by different specialties. Okay, now we are also using. So you can see, since different branches have used, they have given different names. So all are the names of actually PRP, a bit this and that. So if you search for literature, you can search for anything of this nomenclatures, and you will get ultimately about PRP only. So different branches, they have given different names. Somebody says regenerative medicine, somebody says orthobiology, somebody says prolotherapy, but all are same. So rationale means, as I told you, it is again initiate the tissue repair, and how it does, mainly the growth factor. Cytokine, lysozyme also have some positive effect. So what we do, we inject growth factor in the tissue. So it is a supra physiological release of growth factor to jumpstart healing. So this is the main main background. Okay, so we want to inject the growth factor. So advantages. So advantage here, you don't have to buy anything from pharmacy. Blood is the patient's blood, and so there is less chance of adverse effect, and at least no allergy. Okay. And disadvantage is lack of standardization till now, since you have understood that different specialties have used for different purposes, and so ultimately there is no standardization as such. So you can follow any of them, and so there is so much difference between the method of preparation of PRP. Activation is a concept that you have growth factor in the platelet, but after injecting, if growth factor doesn't come out from the platelet at the same time, say after it comes slowly and slowly getting absorbed also, then the supraphysiological concentration inside the tissue will not occur. So that is the concept of activation. The activator is mixed with the blood so that all the growth factors come out at a time. But then there are it is not accepted by everyone. Many people says that activator you don't have to mix, and our normal tissue, body tissue, acts as a activator. And as soon as you inject, all the growth factors come there only, platelet at a time. So RBC, if it is mixed, because while segregating the platelet, some RBC may remain. So should it remain, or we have to remove that? Spin means here one spin, two spin method. How blood from blood it is separated. So this is also another thing. So these what I'm saying is that these are the areas where different literatures are different. I mean, they do not match. So somebody used one spin, somebody used two spins. Platelet number. Now, how much platelet count should be? Say one person's. So this is fold special means somebody used 2 to 3 times of the base level platelet. Somebody used 6 to 8 times concentration. Somebody used 4 to 6 times. Somebody 8 to 10 times. So how much concentrated you made the collected platelet? Okay. I mean, if you calculate the number of platelets per ml, so you will understand that how much, if it is 10 lakhs per ml and at the starting it was 2 lakhs per ml. So you know that it is 5 times concentrated. So that is what. And this is not the only question. Another question is the absolute number is also important. Like how many platelets I have injected. If someone has say at the starting 1 lakh per ml and you are making it 5 times concentrated, that is only 5 lakhs per ml. And another person has 2.5 lakhs and you have concentrated 3 times. So it is less concentrated, but ultimately it will be 7.5 lakhs. So total number of platelet is also important or not. So that is also another question. So that is also, I mean, it differs from study to study. Now, image guided, we are very much sure that now you have to do all procedure image guided. No, I mean, blind injection, there is no place for it. So leukocyte concentration, as I told, RBC should be there or not, like WBC can be there or not. Light activation, this is also a type of activation. So these things are different areas where actually platelet preparation differs. But as I told you, how we prepare, we always use machine made. No handmade platelet preparation. Of course, we always use machine made. Activator, we do not use any activator. RBC poor. In our platelet preparation, there is no RBC. We use a gel in between, so RBC is not there. SP1 means one spin. We use only one spin. So just I'm telling you, with one spin also platelet can be made. Platelet concentration, maximum 6 to 8 concentration we are using. So say only six fold, not more than that. So growth factor. Not growth factor. This one is your. I forgot what is. So this one. No, this is not there. This one, okay, G I have forgotten, whatever. So leukocyte rich and light activation is not there, of course. Leukocyte rich, why I have written? So some leukocytes are always there. When I am isolating the platelet, some leukocytes always remain in our technique. So we are not going into definition. How practical aspect you have understood, mainly the tendinopathies, of course, in different joints also, we are using the platelet. And our intention is to regenerate. Here, one important thing is, okay, one spin method, just take the blood, spin once, and you will get, actually there is a gel in between. Below the gel, it is the RBC, all RBC. Above the gel, it is mainly the platelet at the junction, just above the gel. And after that, it starts the plasma with WBC also. So while taking out the platelet part, actually, then some amount of WBC also comes. That's why we say that whatever we are using, that is WBC rich, not WBC poor. And we can use two spin method also. Then what we will do after first spin, we will take out the plasma. We will spin it again. Then if there some platelet pellets are formed, it is so much concentrated and platelet pellets are formed, then just separate the platelet pellet, discard everything, and use this one only for intervention. First, you go for machine selection. So you can buy a cheaper one, you can buy a very costly one also. Costly one has some advantages. It is stable during rotation, and here it can break the vials if you increase the speed, and sometimes speed is also whatever they claim, it is not there. Temperature control, these are temperature control, these are not temperature control. So that's why we say that within half an hour it should be, after taking out the blood, within half an hour that platelet should be within the patient's body. You cannot freeze it, you cannot heat it. So that temperature control should be there, from body temperature to body temperature. So these are we are using some pre made kits actually. So gel is there, some gel part is there, and ACD vial. These are ACD vial. So there are multiple systems. So as I told you, RBC is down, and then if there is a gel or not, but then just after above RBC, there is PRP. And then above that, this is platelet poor plasma, means plasma and WBC is there. So our intention to aspirate this PRP, but some part will come in your vial, of course, if it is a one spin technique. In two spin technique, you will get this type of pellet. And those people who did experiment that we do not want WBC also, then they used some special type of WBC filter. But I think that much is not needed. So you can follow any one method, okay? Let's see. So many people have used many different. Okay, so some important thing, like our is 3500 rotation for 15 minutes. We use 3500 rotation for 15 minutes for a single spin technique, and we get RBC. So here one important thing is, while giving PRP, it's a prolotherapy, tell the patient that you will get benefit after 90 days. Okay, it is not for pain relief. Immediately your pain will not be relieved. It is for regeneration, and regeneration comes slowly. So it is nearly 90 days is required. So that's why I told, do not use this method in a acutely painful patient. You use this method in a chronic pain patient, where under ultrasound you see that there is degeneration is the main problem. Then only you can regenerate. Okay, so there are evidences, though as I told, everyone doesn't accept, every study doesn't accept, but we have some systematic review, meta-analysis to say there is level 1 evidence that PRP efficacious in patients of symptomatic tendinopathy. I will also say that in tendinopathy it does wonders. So Achilles tendinopathy, the systematic review, good thing. So there are multiple studies. Negative studies are also there. Here, okay, this much only for skin sharing is stopped. Okay, so this much only. Anyone has any question, please tell me, and otherwise we will finish the class today. Any question from anyone? Actually, the whole treatment part we have summarized in one module. As a pain physician, whatever we do, they all can be fitted in the full concept. Actually, this is the whole concept of treatment. So, and then you can of course read in detail, but this is the concept. So, anyone wants to ask any question, please try to read the study materials and all we have given in the app. Once you read, then only you will have some question. Otherwise, question will not come to your mind. and that's okay. Okay then. Good night for today. Thank you.
Okay, thank you.